All right, well, welcome everybody. My name is Katie Lord. I am the Illinois Hospice and Palliative Care Organization Education Coordinator. And today I've gathered some of my colleagues here so that we can do a multidisciplinary panel discussion on medical aid in dying, also known as MAID by the shorthand. And so you may ask, why in the world is I-HPCO doing an education series on medical aid in dying? That's not even legal in our state. Well, currently, the state of Illinois does have legislation that is currently in process and has been presented to make medical aid in dying accessible to Illinois residents. And from what we know so far, it is highly likely that this legislation is passed into law in the year of 2025. So what we want to do today is to bring some awareness to that bill, bring some initial thoughts to help prepare our members and your different organizations to start thinking about what that may look like for you as a hospice and palliative care practitioner. By no means is this going to be an all-encompassing discussion today. This is intended to just be a foundational piece to help start getting your wheels turning and start preparing you as a caregiver to start to have some quality conversations as we anticipate learning more about this bill and potentially law in 2025. So I want to take the opportunity to introduce everybody who's sharing with us today. So I'll start, as I said, my name's Katie Lord. I'm a registered nurse with Vitas Hospice, but professionally, I'm here with I-HPCO. I work for I-HPCO as our education coordinator, and I have a few colleagues joining me today. We have Ellen Byrne. If Ellen, you want to introduce yourself and kind of your affiliation, and we'll go from there.
Sure. My name's Ellen Byrne. I'm the Director of Policy and Government Affairs for the Illinois Hospice and Palliative Care Organization. And I'll pass it over to Patrice.
Hello, I am Patrice Martin, and I am a licensed clinical social worker. I currently am the Director of Grief Support at Lightways Hospice and Serious Illness Care, and also, like Katie, a member of the I-HPCO Education Committee. Sorry, Joe, passing it on to you.
Yes, thank you. I'm Reverend Joe Green. I'm a chaplain, but I serve as our corporate director of spiritual care and bereavement with Unity Hospice and Palliative Care. We serve among our offices. We have 3 offices in Illinois, serve both the metropolitan and the rural areas of Northwest, and Southern Illinois.
Awesome. Well, thank you guys all for joining me today. I'm excited to have differing perspectives and really bring a full spectrum of support to our members today as we kind of dive into medical aid in dying. So a little bit of an introduction. What is medical aid in dying? Oftentimes when you hear about medical aid in dying, your first response is what many of us have heard. It was like a Dr. Kevorkian. It's this dark, very complex, ethically challenging physician-assisted suicide, and it causes a lot of emotional responses as it is a very heavy ethical topic. However, current practices are very different from what you may have heard or thought or experienced in your personal and professional walk. So what medical aid in dying is it is a current practice where 2 physicians will provide a prescription to a person who is 18 years or older, who has a qualifying terminal illness and has the ability to autonomously self-administer a medication to end their life. So this is a little bit different. There's several states who already are utilizing this, notably Colorado, Washington, Oregon, District of Columbia. There's several other states in the nation who are also considering making this accessible to their residents as law. But we really want to focus on, okay, what is Illinois going to do with this? And how does this impact hospice and palliative care? Because we are very used to having challenging discussions about end-of-life autonomy and decision-making and comfort, and understanding that I-HPCO as an organization, our goal is to promote and enhance end-of-life care, whether that's through education, advocacy, support services. We want people to have end-of-life care that's dignified, comfortable, and meaningful. And so with introducing the possibility of medical aid in dying, IL-HPCO has a neutral stance on the legislation itself, but understanding that there is a diverse range of options for people in end-of-life care, and understanding that this potentially passing is just another one of those options. So we really want to start having some of these discussions so that we can start to provide support to our current members, start having conversations as individual organizations, and also start to prepare to have some of those conversations, whether that's with current patients that we're actually caring for, or members of the community that we are having conversations about end-of-life care with, as this starts to gain some traction and publicity going into the new year. So just so everybody's aware, I know one of the initial questions that I had is, how many people are actually utilizing this? So in some of the data that we have from other states that currently have this as practice, it looks like of the patients who choose to receive this prescription, over 80% of those patients are actually utilizing hospice and palliative care for support in their end-of-life management, which to me was really excellent news. I know in Illinois, we're really pushing for more people to be accessing and utilizing hospice and palliative care resources. And one of the concerns that has come up with medical aid in dying is that going to dissuade people from utilizing and accessing hospice and palliative care? So the statistics tell us that that's not likely going to occur, because 80% of people are still utilizing hospice and palliative care options, which is great news, but also tells us that we need to prepare as a community, because 80% is a really big number in healthcare utilization. So we want to make sure that we are getting a good understanding of what we need to do to prepare to support those patients. The other piece of statistics that I found interesting was, of all the patients who do obtain this prescription, it's only about half who choose to actually administer the medications to themselves and utilize the prescription to actually end their life. So as we learn more and we gain more traction throughout the year, we are going to be hosting some additional educational resources to go into some more of those deep questions about autonomy, about some of the ethics, about some of the nitty-gritty details. That's not the goal of today, but I wanted you to at least have an understanding and some tangible numbers to start to understand the reality of what this looks like in practice. So knowing that we've kind of started there and what it's looking like elsewhere in the country, I wanted to pass things over to Ellen. We're so lucky to have her with IL-HPCO as our kind of advocate and our legislative liaison. And she's going to help us break down some of the key points of what the Illinois legislative options look like currently. Understand that legislation is always living and breathing. So some of this information, it may change. So always be on the lookout for updates that we'll be sending. But I want to give this on over to Ellen to start to break down what this is going to look like for Illinois.
Sure. Thank you, Katie. So right now, the bill that we are discussing was introduced in 2024. We are told it will be reintroduced in the General Assembly of Illinois in 2025. The title is the End of Life Options Act. And when the actual language of the bill is introduced, we'll be able to send that out to members so that you can review it yourself. But currently, just to highlight what the bill does, it establishes the right of a mentally competent, terminally ill adult person to request a prescription for medication to peacefully end their life. By qualifications are that the person is over 18 years of age, that at least 2 physicians have given them a diagnosis that is terminal within a 6-month period of time if the disease follows its natural course, and they have to meet requirements for mental competency, which does include an assessment by a mental health professional. The law also prescribes not just the eligibility criteria for the patient, but also the processes and forms, state forms, that clinicians and individuals must use to participate in the medical aid in dying program. It requires fully informed consent on a number of checks and gates to make sure that this is truly what the patient does want to do, that they're not coerced into this, and that it is a persistent request, not just a single request. So that's very important. It also requires that fully informed consent includes sharing information about alternatives to medical aid in dying, such as comfort care, palliative care, hospice care, and pain control, and that a referral to hospice is suggested to be made to those patients that would like one. Additionally, it's important that the law does also provide protections to healthcare professionals and to their employers, such as hospice. And those protections go two ways. Clinicians who want to support patients to end their life through medical aid in dying are allowed to do so, and an employer can't prevent them from participating and providing information. The employer can prevent them from doing it within the context of their job with a hospice, right? But it cannot prevent them from participating in medical aid in dying outside of their employment or contract with a hospice. On the other hand, the law also provides protection to clinicians who don't want to participate in medical aid in dying, and that they cannot be discriminated against or fired or demoted in any way, and they may choose a right of conscience to be uninvolved in medical aid in dying. And then the final requirement within the law is that there is quite a lot of data collection, both of who is requesting prescriptions for medical aid in dying, and then a second collection of data around people who choose to actually utilize medical aid in dying and die by ingesting the prescription. So that will allow the state to really track what's happening in the state, who are the clinicians participating, and then who are the patients that are participating, and learning things about them. So I'll kind of close it there.
Awesome. Thank you so much. So knowing that there's specific qualifications and protections for individuals and organizations, I think is a really key piece to understand, which brings us kind of into the next part of this discussion, where we really want to start to address some self-awareness topics. Hospice in itself tends to be a very gray area that handles a lot of emotionally charged and ethically challenging conversation topics. So we want to take the opportunity to have a couple of different perspectives so that you can start to chew on this a little bit. And we encourage everybody to, after viewing this, sit and start to do some self-reflection, but then also start to have some conversations with your colleagues and as an organization to start to understand what this feels like for you, and what some of those key areas of self-awareness are. I wanted to introduce Joe to really start to bring some of that understanding to our discussion today.
Yes, I'm continually reminded that we serve a very diverse community. We sign up for that when we come into this work, and so I often say it's not about me. Now, that is not to say that I am asked to violate any of my own personal convictions or opinions, but I will say that I don't always agree with what my patients decide or do, the direction they take in any aspect of their care. But especially when we deal with religion, we know is can be a very angular and topic, and drive a lot of what we decide. And so we respect that. We support that, whether we agree with it or not. And so when we come to decisions about the direction of healthcare and life and our views about what authority we embrace for that, then I have a sense of strong responsibility first to provide compassion, listening, understanding, and even direction when it's solicited, with respect to individuals' autonomy and certainly the boundaries that we set and what we can participate in. I'm an advocate of a clear declaration of the company of a company stating our place and the limits to what we can do and the availability to what we can provide. And then knowing as an individual that I have the freedom too. I'm protected in my own autonomy, whether to advocate or to participate or facilitate to any degree. So I know these are extensive discussions to be had and need to be had with all of those in authority from every discipline represented. I know ethics are a big part of this. Patrice, you're going to speak more to that, I believe. Go ahead.
Yeah, as I learn more and more about MAID, I've been kind of paying attention to what my own personal reactions have been, and it's just interesting looking back how much I've fluctuated one way or the other, not even that, but just questions that I have to better understand this. So I think I think we're all being tasked. I think everybody needs to really reflect on what their own personal thoughts and feelings are about this as they learn more about it. What helped me a great amount was to learn more about it and to find out the ins and outs of it, and talk about those ethical considerations. So, ethical challenge is basically when there's no right or wrong answer, right? So we deal with those every day in hospice. We're very good at it. I would say we're probably one of those professionals that would be the best to take on a task like this, because, Joe, like you said, we respect other people's right to autonomy, their right to living the life they want to live their way. And we have had to work with people where we didn't agree with their decisions. So we deal with that gray area. And I think MAID is going to push that a little further for us, and where we're really going to have to look inside ourselves and evaluate what our own reactions are. In looking at ethical considerations, I can imagine we're going to have people on one side of, well, how do we bring this up to somebody? We don't want to influence someone. We don't want to push them into it, but we want to make sure we're giving them that option. There's so many areas where we're going to be challenged with not exactly knowing what to do, which is why I'm so glad we're doing this ahead of time, so that gives us time to process this on a personal level, and then also as a group and as a team and as an organization, as a community, as a group of hospice providers. So another ethical thing may be concern about vulnerable populations. Again, anyone being influenced to do this for the wrong reasons. How do we determine somebody's mental capacity? There's just a lot of things that I think we're going to be tackling. But again, as I feel like we're in a good place to do that because of our work history and experience.
Absolutely.
Katie, I just wanted to jump in about the potential fear people have that medical aid in dying in Illinois will discourage the use of hospice or will decrease access to hospice and palliative care. And just with respect to the language of the law, and then how it's played out from a practical standpoint in other states. I think you said in the introduction that the vast majority, 85% or more, of patients who are participating in medical aid in dying are also enrolled in hospice. So I think it's important that people consider that people in general are not to be discouraged from participating in hospice and palliative care. And in fact, it's explicit in the law that informed consent means that the attending and consulting physician are to outline the risks and benefits of all kinds of end-of-life options, including comfort care and palliative care, hospice, pain control. All of those things are to be discussed with the patient in addition to the option of medical aid in dying, and a referral to palliative care should be made.
Can I add to that? I'm thinking too, how important it is for us as a community to be clear and educate on what this is, so that there's, we are already thought to speed up or hasten death already when we haven't been doing that, right? So there's already been that misconception that we've been battling every day. So I think this is really going to challenge us to communicate this in the best way we can to a diverse group of people from all different cultures, religions, educational backgrounds, and abilities. So it's not going to be easy, but it's going to be real important that we educate ourselves so that we can really explain this in a very helpful way.
But I add something along our idea of self-awareness, and this is a note to self, that we do come to this, and our convictions will inform the decisions that we made and the direction that we go, but not to come with an automatic knee-jerk reaction or totally preconceived perspective on this, but to be open to the possibilities that it offers, the positive impact it can have for people to know that they have a choice, that we have choices, and it may not be as straightforward as most complicated things aren't. And so to give myself, to be fair to myself, to examine and have these process-oriented discussions, and there probably is as much benefit in that process as there is in the conclusions that we actually draw.
Yeah,
absolutely. And I think one of the really important things to understand as well is medical aid in dying is not hospice and palliative care. It is a separate thing. However, as the hospice and palliative care community, like you said, Patrice, we're going to be the most well-versed in how to help have some of these supportive conversations. So while medical aid in dying and hospice are two separate things, they're kind of traveling along the same road. So I do think that it is our responsibility as hospice and palliative care and serious illness care practitioners to become aware so that we can have some of those quality conversations. And I think this is an incredible opportunity for us to be able to showcase the care and the work that we are already doing and help the community have a better understanding. So I think while there's fears that this may cause people to not utilize hospice and palliative care, I think this is an incredible opportunity for us to actually gain more limelight and advocacy and awareness in the community, whether it's suburban or metropolitan Illinois or down into rural Illinois as well. I think this really presents itself as a positive opportunity to have quality conversations about serious illness care and end-of-life care. So I encourage, each of you coming out of here to really start to focus on what it is that we bring to the community. And that's where, our theme for the year truly as IL-HPCO's education focus is back to basics and understanding the care that we provide and providing the right type of care to people at the right time, at the right location, and really focusing in on that so that we can continue to help people understand what it is we do, whether or not they want to pursue medical aid in dying as a conjunctive tool. This gives us as hospice and palliative care a really great opportunity to shine through this topic coming to light. So knowing that this gives us the opportunity to have more conversations in the community, I think we'd be remiss to not at least mention How do we start to handle some of these tough questions? What are some of the tough questions that we might start to field from the community as this gains more publicity out in the news, as this starts to spread throughout the healthcare community and outside of the healthcare community? And I think the biggest thing is preparing ourselves to have quality end-of-life conversations. But then outside of that, I'd really like to take a moment to talk about maybe supporting those who maybe don't qualify for medical aid in dying. I think we've all had experience with patients and family members who do wish that they could hasten the dying process, which is not what we do. But now that they may hear that there's an opportunity and they may lack total understanding of what medical aid in dying is, I think that opens up some questions and concerns for those who aren't able to self-administer or maybe aren't in the mental capacity to make decisions for themselves, and kind of how we can support those community members and those patients and family members in these coming months who may express frustration that this isn't an option for them.
Katie, I wanted to just jump off on something that you mentioned about those that don't qualify to participate in medical aid in dying. And I think that's an important area for our members to understand as they address questions from their patients, right? So obviously, one of the things that limits this is age. You have to be an adult, 18 years or older. You also have to be mentally competent. And then the most important thing, I think, for our patients, especially those with debilitating neurologic illnesses, is that it has to be self-administered. And so we know right now that there are going to be patients with Alzheimer's disease diagnoses and ALS diagnoses that by the time they are considered within that 6-month window of death, they may be unable to administer the medication themselves. And specifically, the law states that the self-administration has to be affirmative, conscious, voluntary action performed by the patient themselves to ingest the medication. And it cannot be administered through a parenteral injection or infusion. So it is important to know and to deal with the emotions that are going to come from that patient or their family because they are not able to participate.
And I'm not sure if I'm jumping ahead, but when you think about grief and you look at how can complicate a person's grief, one of those things is when you don't feel like you did what your loved one would have wanted. Like that can create a risk where you're going to struggle a little bit more because you might have some regret about something that was done. So that just thinking about that and how important incorporating the family's reactions and them having a good understanding of what the patient's wishes are, and no questions about how this decision was come to, or that already that's a hard thing for us to accomplish without MAID. So I think too, just doing a lot of that early support and processing with families is gonna be a very important piece of this.
Absolutely. And I think it'll be a beautiful opportunity for organizations to really ramp up their interdisciplinary discussions and to work together as all disciplines to support patients and families. We already do a lot of work on the anticipatory grief and the follow-up bereavement, but sometimes that can feel a little bit siloed. You have nursing over here, you have chaplain over here, you have social worker here, and you can throw in some of the integrative therapy and volunteers, and sometimes it feels a little siloed in some cases. So I think this is a great opportunity for the interdisciplinary nature of hospice and palliative care to really come together and shine in the support that we can provide in some of these ethical conversations that we can help not sway families one way or another, but help support and hold that space for them and with them to have some of these conversations amongst themselves and to help them have a better understanding of what they can and can't do, and then also how they can start to process that before a patient passes, and then how they can work through that afterwards as well, because I think this is something that will potentially complicate grief and part of that bereavement process. But again, as you spoke to earlier, Patrice, we're the perfect people to be facilitating that because we're already so used to providing that support. So this is just another opportunity for us as individuals to grasp a better understanding of the interdisciplinary team. And then as organizations as well, really taking a look at how your interdisciplinary teams and how you utilize all of the members of that team to provide support and make sure that you're gearing up for a really all-encompassing whole care for that patient and their families.
Back to basics.
Exactly. It all comes back to basics. And so I know there's probably a lot of questions, a lot of thoughts, a lot of feelings that have been stirred up in, the time that we've spent together today. And our goal by no means is to be able to address every concern or even to sway one way or another. The goal today is to just help you have an understanding of what this is so that you as a person, as a professional, as an organization can start to deal with some of this, process some of this, and have quality conversations coming out of this. So kind of a where do we go from here? There is a specific timeline that will be in place. One, this has to be heard. And then two, there's some details in legislation that have to go into practice if this were to get the votes that it needs. So Ellen, if you could maybe kind of touch base on what this will look like in reality, so that people can kind of understand the time frame of this.
Sure. So our General Assembly just began their session last week. New lawmakers were sworn in, and the deadline to begin introducing bills is coming up in the next couple of weeks. So probably by mid to late February, we will have a good look at what this legislation is actually going to look like. It does take a number of months for legislation to move through the committee process and the vote process in both the House and the Senate in Springfield. So I would anticipate that if this law passes, it's probably going to be April or May before that occurs. And then at that time, the governor has 60 days to either sign the bill or veto the bill. I think that's very likely that he will sign that bill within 60 days. So that gets us to maybe the middle of summer. And then the bill requires that this MAID program is operational in the state by 6 months after the governor signs the bill into law. So at that point, we're looking likely at the beginning of 2026.
Excellent. So hopefully that helps you understand that this isn't a decision that's going to be made and put into practice tomorrow. We do have a little bit of time. However, it's so important to start to have those conversations and to start looking into your organization to be prepared. Because as we all know with change can be challenging and time moves fast when new things are introduced. So taking the opportunity to put some of that groundwork and framework in place now so that if the bill does end up being signed this summer, you're already in some positive forward motion with this so that you personally, professionally, and your organization as a whole can really start to move forward with that to prepare for the beginning of 2026. So wanted to just kind of close out today with just a opportunity to remember what it is that we do and who we are as hospice and palliative care. The healthcare landscape is constantly changing. 2025 is going to bring changes on a national level to hospice and palliative care, which you're all working through already. But the beautiful thing is I just encourage each of you to remember what it is that we do. Again, return to that back to basics philosophy of what hospice and palliative care does, who we are, and ultimately medical aid in dying doesn't change that. It doesn't change the care that we provide. It's just something that we need to become aware of, both personally and professionally, so that we can continue to be those advocates for excellent end-of-life care, to continue providing compassionate, dignified end-of-life care, start to facilitate those conversations, and work together within the entire state of Illinois to facilitate those conversations and help people in some of their most trying times. So thank you all so much for taking the time to view this discussion. Hopefully it spurs a lot of continuing conversations. Coming out of here, we will have a packet attached to this with just some basic information that Ellen's put together to help you dive into some additional resources. And then throughout the year, we are going to be having additional educational topics. So keep an eye out on your member updates and education updates, so that as time moves forward, we will continue to dive a little bit deeper. And should you have any additional questions, or if there's ways that I-HPCO can help support you and your organization and maybe facilitating some of these conversations, we're happy to do that, because our goal is to support you as the hospice and palliative care organization. No matter what your stance is or is not on this, our goal is to provide education and support. That is the core of who we are at I-HPCO. So should you have any questions or concerns, please don't hesitate to reach out, and we're happy to support you in any way we can. So I want to thank you all so much, Patrice and Joe and Ellen, for taking the time today. And we'll go ahead and close out. Thank you guys so much.